Master of Public Health and a board-certified psychiatric pharmacist. Welcome, Ben.
Thanks for having me. It's great to be here.
Yeah, thanks so much for coming on. Let's start out. Why don't you just tell a little bit about yourself and what got you to this path of being a spirit pharmacist?
Yeah, well, I guess like the kind of like nutshell version is that I'm trained as a psychiatric pharmacist, which means that I did 4 years of pharmacy school. It's a doctorate level program, and then I did a couple years of postgraduate residency training. Did the first just in general acute care at Scripps Mercy Hospital in San Diego, and I did the second year at UCSD Health, and that was purely in psychiatry. So it was like in that year that I got advanced training in different types of like psychiatric settings, and really became an expert in psychiatric types of medications. But I would say that my educational path was, I don't know, inspired by psychedelics, but inspired by psychoactives, and psychedelics were a big part of that. And I just had an experiential and intellectual curiosity about psychoactives as a teenager. I found them fascinating. It inspired me to study pharmacology as my bachelor's in undergraduate. So I don't know, without going through like an entire like cosmic travel log and things like that, it was kind of like, well, I have advanced and specialized training in psychiatry as a pharmacist through the sorts of pathways that are available to do that. It's been a much longer journey overall. Like I became fascinated with psychedelics around age 17 or 18. I'm 37 now. Right.
Okay.
I graduated pharmacy school in 2014, less than 10 years ago. Right. So my interest in psychedelics really kind of drove and predated my clinical training, but it really was the clinical training that put me in the position to do the kind of psychopharmacology consulting. It's a tough word to say, even when you are that. And the education that I do now. I worked in academia after the psychiatric pharmacy residency. So I was a professor of pharmacy. I taught psychiatric pharmacy at a college of pharmacy for almost 5 years. And I spent a lot of time there doing, let's say, like academic blogging about psychedelics when I was just like developing my website, or even the first version of my website. We're on 2.0 at this point in time. And also use the time to like publish in scientific journals relating to psychedelics, particularly literature review and like literature synthesis around drug interactions and psychedelics, giving continuing education talks to, other professionals, physicians, pharmacists, things like that. So I spent a lot of time, I guess, becoming specialized in psychiatry, and then really diving into psychedelics and how they interact with psychiatric medications. And that was kind of how I got to the position of being an entrepreneur that has a website that does consulting and education in this sort of field or area.
Well, because it's so important. It's so important, and anyone that's looking to use psychedelics really for any reason, it's just such an important aspect of it. Before we get into all of that, tell me about. I'd like to hear about what is in the pharmacology world. What is the thought on psychedelics these days?
Oh, well, I think that there's lots of different thoughts out there, and it maybe depends on who you're talking with. But I really think that the unique part about psychedelics, right, is not that they have drug interactions or that they have metabolism or, like things like that. Is sort of, well, I do a lot of education in this area because I want people to understand in some ways that they really are pretty similar to other types of substance. They have predictable drug interactions, metabolism, things like that you can utilize to, optimize a person's experience or reduce risk. But the special part about them is the experience, the subjective sort of qualities or effects. And I would say that in pharmacology right now, the sort of hot debate or big outstanding questions are, what part of the psychedelic experience or the effect of psychedelics really drives the outcomes that we're seeing in clinical trials? And is it the fact that they had a mystical type of experience, or an experience with a really positive subjective quality that felt deeply spiritual, personally significant for the person? Or
Right.
is there some other effect of these substances around neuroplasticity, maybe unlearning, relearning types of mechanisms that really kind of allow the person to, perhaps along with some kind of integration or other support, make the practical changes that they haven't been able to make for whatever reason in their life up until that experience. So I think pharmacology is really interested in psychedelics and finding out why do they produce this kind of subjective effect and what are the mechanisms there? And then how do they produce this kind of neuroplasticity mechanism? And is it really coupled or one and the same with a subjective experience? Or could there be a way of parsing out these properties and perhaps even developing non hallucinogenic
Hmm.
neuroplastogens for perhaps illnesses like a bipolar 1 condition or schizophrenia, where it could really help them with their condition without kind of like running this risk that psychedelics do have of precipitating psychosis or mania in persons that are predisposed to those kinds of things. So I would say like that's probably kind of at the heart of the mystery of psychedelics as far as pharmacology is concerned right now. And it ruffles some feathers, right? It ruffles some feathers to, of course, it's the subjective experience. I kissed God. Like, how could that not be the reason that I'm feeling better or doing better in the weeks or month afterwards? And, as a person that's experienced psychedelics, it's really hard to discount that is impactful and plays a big role in it. But, one of the things that, frankly, cheeses me off the most about prohibition is that it's this kind of state where you're not allowed to ask legitimate scientific questions about things. It's like, okay, that's a box of psychedelics or just substances where there's no therapeutic value. There's all of this risk. So just don't even ask questions about that category, right?
Right.
And okay, that's ridiculous and anti-scientific. So when I see the psychedelic community now being like, okay, we can ask this question about neuroplasticity of psychedelics, and like, no, that's ridiculous. There's no point in asking that. I'm like, come on, guys. Like, we're just in the interest of furthering knowledge. This is a very good question that needs to be asked and explored. So that's kind of like where I like sit on it, even though, yeah, okay, I recognize the experience is pretty dang special. But there's other aspects of psychedelics pharmacologically that are special, like the neuroplastogenic types of properties, and we really need to get to the bottom of that too. Yeah.
So have there been studies in the past trying to get something to imitate that neuroplasticity? What makes it do that? Because you said maybe in the future they might have something like this without the
Well,
psychedelic.
well, we've been really focused, I would say, on like the serotonin 2A receptor and the sort of like downstream effects of stimulating the serotonin 2A receptor. That's been, I would say, the crux of psychedelic research for really the last like 50 years or so. But it's evolving at this point. It's getting like very interesting. For example, just maybe last month, the month before, there was an article that found that psychedelics like psilocybin or LSD bind extremely tightly with nanomolar affinity to a tyrosine beta kinase. So that's a receptor on the outside of a cell that then directly stimulates neurotrophic factors. And if you block this receptor, you block the neuroplasticity relating to psychedelics. So this paper, it's preclinical type of like stuff. It's, petri dish, like in vitro type of experimentation.
Sure.
But this paper was pretty strongly suggesting that the neuroplastogenic aspects of psychedelics, particularly psilocybin, LSD, the ones that they tested, maybe isn't dependent on serotonin 2A receptor activation, where it still seems that's the crux of our thinking as far as where the subjective effect comes from. But even that's been questioned recently. There's been more articles suggesting that those serotonin 2A receptors are not just on the outside of the cell, they're actually also found on the inside of cells. And to get psychedelic effects, it requires the drug to bind to that receptor on the inside of the cell. And that might be why I would say like more polar drugs that bind serotonin 2A receptors aren't always psychedelic. Like, for example, 5-MeO DMT as a parent
Mhm.
molecule is very psychedelic, maybe entheogenic to the bone, right?
Right.
But then its metabolite, bufotenine, seems, well, it depends who you asked. Alexander Shulgin says not psychoactive. Jonathan Ott, a little bit of psychoactivity. but it's fairly, I would say the consensus is that it's not a really strong psychedelic if it's a psychedelic at all, but it can really tightly bind to those serotonin 2A receptors still. So it's a little bit of a mystery as far as what properties of a drug causes it to be a psychedelic. Is it really that it's binding to the serotonin 2A receptor and activating like a different intracellular mechanism? That's been proposed. That's like functional selectivity or like biased agonism. That's like one kind of like theory. But more
Okay.
recently, there's been this kind of like idea of intracellular receptors being necessary to have or achieve psychedelic effects. So I would say that it's an extremely exciting time for psychedelic research. It's probably these things should have been discovered 30 or 40 years ago potentially, but we
Yeah.
may not have really even had some of the molecular technology to do the level of intricate experiments that they're doing at this point. And it's fascinating stuff. It's fascinating stuff. I really think in 10 years we're going to be kind of digressing away from, I would say, like a really serotonin 2A receptor centric perspective and realizing that there's just other things that are necessary for psychedelic effects or other receptors that are perhaps driving neuroplastic sorts of effects of psychedelics.
It is absolutely fascinating. So, do you feel? I mean, obviously, the baton was dropped right back in the whatever
Yeah.
decade we want to say because of the '60s war on drugs, right? And then it seems to have picked back up. And then, like you said, in recent years, I mean, it's just it's all over, right? The psychedelics and mental health is all over the place. Are there a lot of studies going on right now? When did that start back up? Did it
There are
ever
a lot of studies right now. Like the way that you can look at this if you really want to, you can go to a website. It's called clinicaltrials.gov. It
Okay.
has like, different types of search boxes, but there's like other terms. If you just put in psilocybin or LSD or MDMA, it will give you a list of all the clinical trials that are registered under that particular substance at this point in time. And a lot of them are planned, recruiting, not yet active, ongoing, right? So the number that we have with like completed results is growing rapidly, but still fairly small overall. But yeah, there's been just a massive explosion of interest from industry in the last like 5 or 6 years or
Yeah.
so is when it's really gotten picked up by industry, I would say. Like before that, it was mostly MAPS as a 501c3 like nonprofit, and then universities like the Imperial College of London or Robert Carhart Harris's group or Roland Griffith's group at Johns Hopkins. So it was mostly like independent university research, or maybe like Rick Doblin and MAPS' sort of like
Right.
mission with MDMA. But now you've got just all sorts of industry players, startups interested in it, and yeah, it's a different ball of wax. Yeah.
Yeah, yeah, it's definitely all over and mainstream. So, okay, let's talk a little bit about medications and certain medicines, and very simple,
Yeah.
because obviously when people get into different medications that they're on, and they need to speak with you,
Yeah.
make a consultation and do it. But just in general, can we talk a little bit about
Yeah.
medications and these different medicines,
Let's do it.
maybe in particular Aya? Let's start with that one.
Yeah. So just on the topic of medicines, before we even get into drug
Ah,
interactions, right? Like I would say that, it's like, okay, Spirit Pharmacist, like he's the drug interaction guy, the drug interaction guy. Let's go talk to him about the way this medication list interacts with this psychedelic, right? And it's a kind of like, okay, we can do that. Like we can consider these sorts of like interactions out like almost in like a vacuum. But I
mhm,
actually think it's like one of the biggest errors that people make in like approaching me is that they're just considering how does this drug interact with the substance? I mean, fine, like that's one thing that needs to consider, but I'm just sort of thinking every single medication, particularly prescription medications that come through a physician or provider, right, is a surrogate marker for the treatment of some kind of illness, right? So almost before we get to how do the medications interact, it's like the question that's underneath it that is probably preliminary and very important is what are we treating with this medication? And
mhm,
what is the severity and history of that condition? Because when we get into, okay, let's just take ayahuasca. Ayahuasca is different than other types of psychedelics out there because it has monoamine oxidase inhibitors in it. The ayahuasca vine has harmala alkaloids or beta carbolines. They block monoamine oxidase. And in a nutshell, that creates a metabolic vulnerability. That creates a vulnerability to certain foods or drugs causing really severe adverse reactions. Things like hypertensive crisis, and potentially like the consequence would be like a bleeding type of stroke, like a hemorrhagic stroke, right? Or serotonin toxicity or serotonin syndrome. So the drugs that do that with monoamine oxidase inhibitors are ones that boost other neurotransmitters, particularly monoamines like serotonin, norepinephrine, and dopamine. So you've got drugs like the SSRIs, selective serotonin reuptake inhibitors, and their cousins, serotonin norepinephrine reuptake inhibitors, right? So both of those classes of medications, antidepressants, increase serotonin, or SNRIs maybe increase serotonin and norepinephrine. So yeah, they have a severe drug interaction potential with ayahuasca, and there are other things, stimulants, some over-the-counter cough and cold types of things, anything that boosts monoamine neurotransmitters, really, right?
Okay.
But there's a lot of drugs that don't. Not everything interacts with ayahuasca. I think that's a misconception about ayahuasca, is everything interacts
Yeah,
with it.
yeah.
And it's like, well, everything affects everything else in the way like the butterfly effect works, but is that clinically significant and a reason for a person to stop a medication? If according to me, not always, or not even most of the time, unless it's one that really interacts. But kind of going back to it, it's like, okay, so SSRIs or SNRIs are contraindicated with ayahuasca. There's a real risk of serotonin toxicity occurring. Should that person use ayahuasca then? Well, it depends on their ability to taper and stop the medication now. And now
Right.
we're thinking about what's their sensitivity to antidepressant withdrawal. Have there been periods in their life where they've lived well without antidepressants? How long have they been taking antidepressants and what's the current dose? And then again, going back to it, it's like, what is the underlying severity of the condition and what is likely or could happen to them if they did taper? So it's a garden variety vanilla depression that was mild, and someone shed a tear in a doctor's office one day because life was tough that day, and then they got a prescription for something, and it's been a couple of years and they don't really like it. It doesn't really work that great.
Yeah.
Okay, it still could be a chore to taper it for that person because there's a physical dependence that antidepressants cause. But at the beginning of the day, the things that they were affected with were relatively mild or moderate overall, right? Versus I have complex PTSD from horrific amounts of sexual abuse from age 3 to 15. And then I developed a severe panic disorder. And the only thing that ever stopped the panicking was high doses of Effexor. Do you think I can just stop Effexor and use ayahuasca? Maybe. Like, I mean, I'm a proponent of you trying dose reductions. I never want to just tell someone you're not allowed to try to taper unless there's like really, really good evidence. Like the last few times we tapered and tapered appropriately, it was a slow rate of reduction. We didn't do this sort of like abrupt discontinuation. There was a severe decompensation where you tried to hurt yourself or landed in the hospital.
Right.
That situation is going to be very, very different than the person with a sort of like mild level of depression on a lower dose of an antidepressant that didn't really ever feel that there was a benefit. Right. So a lot of the times, you get what I'm saying, is that if you just
Completely.
get asked the question,
Right.
how do SSRIs interact with ayahuasca? They're contraindicated. You need to stop them for 2 weeks ahead of time. Okay, now that becomes telephone with that person. And depending on who they are, it's garden variety depression. They're not attached to it. They're looking for a reason to try stopping it.
Hmm.
Okay, right? That is probably going to be just fine for them working with their doctor, maybe. Where the other person, you tell that they might attempt it, but it might really not be fine for them, and it might be just dangerous for them.
Yeah.
So a lot of the times the question is just so much deeper than how does this drug interact with this other one. I mean, that there's an answer to that question, and it's an important thing to consider, right? It's not like something you ignore, but at the same time, right?
There's
This
a lot
this
more
is
to
this
it.
is why I do consultations instead of
Yes.
just black and white. This is how the drug interacts with the other thing, right? Because why would you need a clinician to tell you the answer to that? You could figure it out probably. Look at
Sure.
a guide
Google it.
somewhere, right? Yeah.
Yeah,
Yeah.
yeah. And that's great to know, because it's such an important, it's so much bigger, like you said, than just this medication versus that one, and is this okay versus that one. It goes a lot deeper than that.
Yeah.
And sometimes people have been on these medications for 30 plus years. I mean, it goes a lot
Yeah.
deeper.
Right.
Hmm.
Yeah.
Hmm. Serious stuff.
Yeah.
Yeah.
So it's like ayahuasca is almost like, from the perspective of that actual kind of like end of the line question, though, what is the drug interaction potential? Ayahuasca is actually a lot more black and white than something like psilocybin is, because it has the MAOI component in it, which creates the metabolic vulnerability, which makes it basically, that's a playing with fire combination. So unless you're skilled with fire spinning and pyrotechnics, like, don't go there. Like, it's a very clear, you cannot mix those things together sort of answer. Whereas I
Right.
think like psilocybin, it's a lot less clear, like whether they really need to taper or could we just use a higher dose. And okay, most people find that the effects are diminished, but not
Hmm.
all of them. Seems like the Johns Hopkins survey suggests that 30% might even remain sensitive to psilocybin while taking antidepressants. And maybe half, 55%, the effects are diminished, but half of those people can get the effect they want by taking a higher dose. So, wow, 30% plus half of a half, that's over 50% of people might be able to get the psilocybin experience that they're after while taking their antidepressant. So, do they have to taper? Now it becomes a lot more about, hey, what are your clinical goals of using antidepressants and where are you at emotion wise right now? Are you looking to taper because you have side effects and you're doing fairly well and stable overall and have some, I would say, like reserve for some emotional turbulence that really could come along with either tapering or beginning to use psychedelics, right?
Right.
Or is it just this sort of position where I don't think I can taper because I'm sensitive to withdrawal, it makes me feel bad, and I just feel terrible at baseline right now.
Right.
Oh man, okay, so maybe you get 20 or 30% less effect. Maybe we can give you a higher dose. It becomes a lot more gray, and we need, way clearer data, honestly, to get like what the optimal decision is. Like I don't know what the optimal answer is, to be honest, but I do know that tapering slowly and washing it out ahead of time is the way that they've done it in clinical trials, and it seems to work fairly well in that kind of way. And I do know that John Hopkins has done a survey where they have people just straight up combine it, and very few, if anyone, is getting any kind of serious adverse effect from that. What people
Hmm.
are mostly noticing are the effects are diminished, right?
Right.
So the third plan, right, is one that I get from facilitators or guides, or it seems like recommended a lot. Like persons will say, it looks like the half life of this antidepressant is 14 hours. So if we take 5 half lives, that's the time that, pharmacologists would estimate is the time to elimination.
Okay.
Okay, 5 times 14, that's 70. So let's take 3 days off ahead of time, and that's what we'll do for the experience. I think
Okay.
it's erroneous. Like, I don't think, like, it's the worst plan in my mind for a couple of reasons. It's like, one is like the John Hopkins survey that they did kind of looked at this situation of the person taking a break or the person trying psilocybin almost immediately after discontinuation, and they didn't get more effect than the persons that just tried to combine it straight up, right? So first of all, I think it's really questionable whether that increases the intensity of effect for someone. And then, yeah, the medication is eliminated from their system after 5 half-lives. That 5 half-life time period for someone that's physically dependent on a psychoactive corresponds with the exact moment you would predict withdrawal to be hitting severely. So it
Mm.
seems like the plan becomes, let's abruptly discontinue the medication and wait just enough for them to enter a pretty bad withdrawal syndrome and then dose them with a psychedelic. And it just kind of like, I don't think that sounds like a good plan. Like that,
Yeah.
I get the logic. Oh, the drug's gone for their system, so we
Right.
eliminated the interaction. Like that, like that's the logic, right? But
Right.
it's not thought through in the idea that antidepressants have long-term neuroadaptive effects that don't go away within 5 half-lives of stopping the drug.
Right.
But within 5 half-lives of stopping the drug, or almost about 5 half-lives after stopping the drug, that's where you can pretty correctly predict when withdrawal is going to begin in a really bothersome and noticeable way. So I think the plan really just sets people up for maybe a mind manifested withdrawal, like sort of experience for the
Mhm.
psychedelic experience itself. And then I
Right.
think it sets them up for integration week, looks like restarting my medication, trying to become stable, trying to untangle what parts of me not feeling so good or withdrawal and the fact I went without my medication versus something that the psychedelic has done or showed me or this kind of
Right.
stuff. So I think it creates a confusing and higher risk situation than just combining your antidepressant with psilocybin or psilocybin mushrooms straight up. But if people are asking, what's the optimal plan? And it's like I pretty much have to revert back to what's been protocolized in a clinical trial, which is the taper and washout kind of method. Um, Even that, though, it seems like the washout periods are inadequate. Like it seems like 2 or 3 weeks is not quite long enough. It seems more like 4 to 12 weeks of the time that you would expect these neuroadaptive effects of SSRIs to reverse and to regain like full sensitivity to it. So
Mhm. I,
what
I
I'm
would
saying
think.
here is the optimal approach is generally unclear, but you just have to follow kind of like best guidance around either tapering slowly or mixing them in a cautious way. But I think sort of the abrupt stop, wait 5 half-life approach is a trap. Like,
Yeah,
yeah.
yeah. Well, it seems very individualized. I mean, there isn't a set standard
Yeah.
for every single person, and it's the same way with. I mean, I guess with pharmaceutical medications. I mean, it's my question
Yeah.
though with the psilocybin though is microdosing, right? Because a lot of people will call me and say, "Oh, I want to come to microdosing because I heard I can use that to get off of my
Yeah.
my antidepressants or whatever." Talk to me a little bit about that.
I don't know, but maybe, right? It's like, well, because the thing is that when you take a dose reduction or stop your antidepressant, less of the serotonin reuptake pump is blocked, right?
Okay.
And blocking that serotonin reuptake pump traps serotonin in the synapse. So I think that antidepressant withdrawal is probably linked to lower levels of serotonin signaling because you're not trapping as much in the synapse anymore. And if the body's really used to it being kind of trapped in the synapse, then it probably results in lower serotonin just synthesis or production, maybe lower expression of the serotonin reuptake pump, like the target for the antidepressant, right? And maybe it results in increased serotonin receptors in a response because it's trying to kind of like recover some of the signaling, right? So I'm sort of thinking that antidepressant withdrawal is probably linked to lower serotonin signaling resulting from lower occupancy of the serotonin reuptake pump. And boy, I wish I knew which thing out there just magically alleviates antidepressant withdrawal. I'm not really sure that there is a thing that doesn't also block the serotonin reuptake pump, and that feels a little bit like do not pass go, do not collect $200, go directly back to where you came from, because it's kind of like, oh, I can't handle this antidepressant withdrawal because of the occupancy of the serotonin reuptake pump. Sure, I've got the solution for that. Another antidepressant that blocks the serotonin reuptake pump. It's just kind of like,
Yeah.
that's not what I'm searching for, right? Whereas very low doses of psilocybin or LSD, they don't block the serotonin reuptake pump, but they do stimulate serotonin receptors, right? So if antidepressant withdrawal is really linked to lower levels of serotonin signaling, and you had drugs that could stimulate serotonin signaling, plausibly, maybe that really would relieve some of the withdrawal symptoms. Maybe it really does sort of restore some of the missing serotonin signaling associated with antidepressant withdrawal. And I've had people tell me, you know, the days that I microdose, the brain zaps go away for a few hours. The days
Mhm.
that I don't, they're there all the time. Right? Like these are not uncommon sorts of stories
Right.
that you hear from persons, but there's just no, like, I can't, as a psychiatric pharmacist that tries to be at least semi evidence based, go
Scientific.
out there and just be like, yes,
Sure.
absolutely, these things are the ticket off of your antidepressant, and they just like magically paper over the withdrawal. Because there is this kind of narrative out there that it's sort of like it's a replacement. It's just a
Right.
replacement. Like you just kind of whipped one tablecloth out and put the other one underneath there, or no one drilled spills a drop of red wine, and it's like a
Right.
magic trick. And it's like, okay, it sounds too good to be true. It probably is, particularly if you're someone that's using higher doses for longer periods of time and you know that you're sensitive to withdrawal, right? You're still going to have to go through the process of a long and slow taper, right? But maybe you get to a point in the taper. I was on 200 milligrams of sertraline. I did these 12.5 milligram decreases every 3 or 4 weeks down to 100 milligrams. I went to 87.5. It was really hard to function all of a sudden. Like the brain zaps were too much. I was getting some sort of nauseous vertigo kind of feeling. Okay, you made it quite a bit of the ways. You very squarely are looking at symptoms that are associated with withdrawal. I mean, brain
Mhm.
zaps, that's not depression or anxiety. Right? That's a neurological kind of symptom, right? Could you introduce a microdose at that point? And one probably one of the biggest blessings about psychedelics is when they work, they tend to work rather rapidly, right?
Right.
So was that a good day? Was it a much better day? Yes. Okay, you might be onto something. There might be a signal there that microdosing could be your ally or aid in helping to complete that taper, but it's not going to replace the need for the kind of long, slow decreases. And then microdosing in general, the jury's out as far as like what the long-term safety of that looks like, as far as, okay, there could be risks of valvular heart disease. That's like the physical risk. And frankly, I've had a lot of people sort of tell me that they went through 1 or 2 months or maybe 3 months of microdosing and it was good for them. And then somewhere between months 4, 5, and 6, it started producing anxiety. It made me
Mhm.
feel irritable and agitated, right? To the point where I'm kind of wondering, is there sort of like a biological ceiling on this neuroplastic effect? If you really dose psychedelics chronically for long periods of time, do they start having different sorts of effects? Right?
Right.
Or is it the person just isn't doing their work and they're, not realizing something about it? I tend to be more along the lines of, maybe there's a real like physical effect here. Because I feel like the other way, if we just discount what they're saying, then we kind of gaslighted them in not doing their work and things of that nature.
Right.
So basically, I'm okay with people doing it if they are going to do the long, slow taper with their antidepressant because there's no replacement.
Yep.
And if there's some symptom, whether it be neurological or psychiatric, that they're struggling with during the taper, and they start microdosing and they notice that that's diminished or goes away, then I think that they're just in a position where they can clearly see that it's helping them.
Right.
But then even then, how long can they safely use it as an ally before microdosing could introduce some level of risk to the picture that's just not really well known?
Yep.
And I get it. I mean, there's probably risks of antidepressant tapering that aren't really well known too. Like you can make that argument, and it's a pretty reasonable argument to make because there's just a real lack of randomized trials that look at antidepressant withdrawal or tapering, the rates of tapering, randomize people to a hyperbolic tapering versus a linear tapering, a
Right.
4 month taper versus an 8 month taper. Who gets off with less suffering? These are questions that we don't even have answers to, right? Which is ridiculous considering the number of people that are taking them and the physical dependence that the drugs cause. So yeah, there's no like real clear or easy answer, but I would say that it's pharmacologically plausible, at least, that microdosing could be an ally, and it's reported to me as well as many others that it is helpful in certain persons.
Mhm.
But there's some unknown there. There's potentially some risk of either microdosing or other problems associated with tapering, and yeah, it's what I can tell people is that if you've really been taking antidepressants for a while and you're really trying to go on this sort of psychedelic or plant medicine path, and you're really trying to get off your antidepressant and start using psychedelics, it is possible. I've
Mhm.
met people on antidepressants for 5, 10, 15, 20 plus years that have
Yep.
successfully done it, right? But it's usually more like we have a consult, maybe a couple of consults, and then I get an email 9 to 18 months later that says, boy, that was a bit of a turbulent passage. And there were times where I wanted to throw in the towel, but it was tolerable, right? We didn't cross any lines in the sand, like severe insomnia, panic, thinking of hurting yourself, stuff like that,
Right.
where it's just kind of like, yeah, we just can't really tolerate that. It's just too risky. And I made it, right?
Yeah.
But very few people have ever really, that I've met, at least the people that I come in contact with and consult with, I mean, I haven't really met any of them that are kind of like, oh yeah, I just stopped that over 1 to 2 months and just had one experience with something, or microdose for a few weeks, and it's just smooth sailing. That was wonderful, right?
Yeah.
Maybe one or two people, but it's like, again, lower doses, shorter term use, extremely dissatisfied with the antidepressant, already knows psychedelics help them, right?
Right.
Yeah.
And it really all comes back again to, and you said it earlier, this isn't a magic pill. This isn't an instant fix. It isn't, if you hear something that's too good to be true, it probably is.
Yeah.
There's other things to be done. It's not just about, popping a microdose in the morning or
Yeah.
going on a journey.
We need to rename them mystical mushrooms instead of magic mushrooms, so that
Yeah.
people get the right idea. Yeah.
Yeah. Let me ask you this real quick, and then I want to talk about what you do and what you offer, because I get this question all the time. Is there something out there that is there something somebody can take if they are on a journey and not enjoying it or going too deep? Is there some sort of trip stopper or whatever you want to call it? I get this question a lot, so I'm curious as to what your opinion is on this.
Well, as far as like chemically, yeah, like
Yeah.
benzodiazepines or antipsychotics, right? Like benzodiazepines through GABAergic mechanisms can diminish effects of psychedelics.
That's
Antipsychotics,
right.
particularly for serotonin-based psychedelics, right? It wouldn't do much to stop a ketamine experience.
Right.
But for serotonin-based, psychedelics like LSD, there is a trial now that gave people LSD and then an hour later, either an antipsychotic or a placebo, right? The ones that
Right.
got placebo tripped for 8 to 10 hours, the standard. The ones that got the antipsychotic tripped for 3 or 4 hours, right? And
Okay.
then it seemed to stop. But whether that's an optimal approach, whether you should just do that because you don't like what's happening in the experience, I think it's very unclear. It's like, when I look at hallucinogen research guidelines, it's basically saying, no, don't chemically intervene unless you absolutely have to, right?
Mhm.
It's saying that the first line is emotional support, and the person should probably just try to get through that experience without using things to like put the brakes on it, right? It's like mostly the benzodiazepine or antipsychotic would even be maybe like one step further than that,
Yeah.
is for the situation where it's like they're so confused and agitated that they're hurting themselves, breaking property, combative with a facilitator or other sorts
Right.
of participants, having like a severe kind of like hyperthermia where it almost looks like a serotonin toxicity, or they actually have a seizure or something. It's like, that's when I'm thinking, yes, benzodiazepines are really squarely indicated, not I took some acid and man, it's
I'm not
making me
enjoying
anxious.
this.
Can I have a Xanax now? It just sort of like, okay, well, particularly if you're taking a psychedelic because you intended to work on some part of your emotional constellation, like fear and anxiety, then
Right.
it kind of seems like you're shooting yourself in the foot. It's like you might be actually trying to get away from that kind of like chemical coping mechanism, or right, this sort of geez, when I get anxious, I need to do this to calm down,
Yeah.
right? Like
Yeah.
maybe it would be a better proof of concept to just go through the 5 or 6 hours of anxiety associated with LSD experience. Eventually, I mean, it really is sometimes like the anxiety with some of these substances. It feels like one of those like Chinese fountain fireworks that just keeps going off. And the level of energy that just doesn't stop feels like a lot, right?
Yeah.
But usually by the end of the day, it does peter out,
It
and
does.
and the nervous system can really sink down into perhaps a more relaxed place than it's been. So I think of psychedelic work as energy work in a lot of ways, and it seems that something about serotonin based psychedelics that really almost like rev up the nervous system and cause like some kind of energetic catharsis. And
Mhm.
sometimes it's just this intense anxiety. sometimes a person actually has like some level of volitional shaking going on.
Yeah.
Sometimes it's a big cry and like grieving that needs to be done and hasn't for a long time. Sometimes it's actually just like gut splitting laughter, like the
Yeah.
kind of laughter that only your closest friends or family have been able to elicit from you, maybe a handful of times in your life, like the kind where it's like, I want to stop laughing. My abs hurt, but it's so funny. Like that kind of laughter. So they tend to cause like a big energetic slash emotional kind of expression.
Yeah.
And for the person that's sort of sitting there like, oh my gosh, I'm so anxious. Can I get it to stop? Right. It's sort of like if you're having that thought, like I would really like this part of the psychedelic experience to stop, right? Then that is almost for sure your proof that you're resisting that part of the experience.
Yeah.
And I would encourage the person to invite that in. Can I feel more anxious? Can I take a deep breath and fill my body with the anxiety and then release it on the exhale? Right? You can
Mhm.
do these kind of like guided imagery things with your own mind, right?
Sure.
Maybe you've got a facilitator that can help you with some of this sort of like somatic processing, we'll call it.
Yeah.
Um, I'd say
Yeah.
like those are the big three: pain, nausea, anxiety.
Yeah.
Sometimes the studies call it nausea, emotional discomfort, physical discomfort. Like these are the big three things that come up transiently during psychedelic experiences that people find really bothersome and cause them to want to check out from the experience, or the other, like, can I just wait it out? Like I get that one sometimes. It's like, so if I start having a bad trip, what do I do? Just kind of wait it out. And it's like, okay, wait it out literally means like I'm going to check out, dissociate from what's happening and not pay any more attention till it's over. Right?
Yeah.
Like no one like, so what should I do? I just kind of like checked out back there. That is the opposite of engage with, try to learn from, understand more about, right? Which is kind of where you're trying to navigate with psychedelics into this realm of self-knowledge, or maybe just catharsis of emotion too.
Yeah.
So, you
You
know,
got to walk through it.
if you feel that the water is boiling and the tea kettle is starting to whistle, make it whistle as loud as possible and let it boil over is really
Yep.
the best advice I could have.
Yeah.
When it really crosses that line into agitation, confusion, combative, hurting yourself, okay, that's the point where you would want to intervene with some type of other chemical entity, like maybe a benzodiazepine. But I really, recommend trying to avoid routine use of those things, or trying to abort certain aspects of the experience because you don't like it. And that's
Yeah.
just not, yeah.
Yeah. Yeah. You got to walk through it. You got to walk through it. There's some things, some work to be done in there, and a reason that it's you're going through that. So
I mean, if you're
okay.
really like if you're really on the like if you're panicking in the psychedelic experience, you're on the doorstep of divinity. Like it's like you're so close. It's like you shot
I
a
love that.
basket into the mystical zone
Just-
and it's going around the rim right now. That's
yeah.
like what it means when you're like panicking in the experience. And you can panic and let it fall out, or you can say, all right, let me be overwhelmed, and it will go into the net,
Dive
and your experience can change on a dime. Like, psychedelics aren't for a thrill. They're not for excitement. It's not like you take acid because you're an adrenaline junkie or something like that.
in.
But there's a really fine neurochemical line between terror and ecstasy. Maybe you've never jumped out of a plane before. The first time you jump out, you're going to jump out with somebody strapped to your back, or maybe you'll be strapped to someone else's back, a guide, right?
Yeah.
Like you're going to have a
Right.
guide for that, because you need a guide, and it can be absolutely terrifying. But the moment that you jump out of the plane and you're in free fall for the first time is probably just going to be the first few seconds are probably just going to be absolutely terrifying,
Yeah.
right?
Right.
But after 3, 4, 5, 6, 7, I'm flying, in the most liberating feeling I've ever had, because I allowed it and there was no other choice, right?
Right.
Because I was just in free fall until it was over. And again, psychedelics aren't a thrill. They're not for a thrill, like riding a roller coaster. But why are we okay getting on a roller coaster and going upside down and through loop to loops and things? Because you're strapped into the ride and you know that you're safe. No one's getting on a roller coaster that has no seatbelt on it, right?
Right.
Right.
And
So
just
it's like
hold
the
on.
psychedelic experience is very much like that. Is like, you know, you're safe. There's no lethally defined dose to psilocybin or LSD, right?
Right.
You did your ABCs and checked demand interactions and yada yada ahead of time. It's like, you know, you're physically safe. The
Right.
question is, am I psychologically terrified or not? Right. And then, okay, that terror can become the most mystical, ecstatic, and liberating feeling if you allow it. But if you think, I'm just going to wait out this skydive until it's over, I'm just going to close my eyes and hold on white knuckled to this roller coaster and not enjoy the loop to loops. It's kind of like you're missing the point of skydiving or going on a roller coaster. And again, the analogy breaks down because those things are about thrills for adrenaline junkies, where that's not really what psychedelics are about. But the
Sure.
idea of safety
Same
being
idea.
buckled in is really similar. Yeah.
Yes. Yeah. Yeah. It's all about that set and setting and feeling safe. Well, let's talk about for a minute about what you offer there at the
Yeah.
pharmacist, because you got some good stuff going on and it's important.
Yeah. Yeah.
I'm gonna put up your
So,
there you go. People
oh,
can click
wow.
right on
Look at that.
there.
Fancy QR code even. Yeah, so basically through Spirit Pharmacist, I offer psychopharmacology consulting and
Okay.
psychedelic education. You know, the consulting I do through a member program or just a la carte consult. So just absolutely anyone can go to my website, click on the consultation tab, and book an hour of time to mostly probably do like some kind of intake session related to some medications or illnesses and planning for psychedelic experiences, but really anything. You just got a
Okay.
laundry list of questions. It's after the experience. You're wondering what impact, if any, medications had. Like I'm happy to consult with people about really whatever they want to talk about,
Okay.
and can do that without the member program. I have a member program that kind of hybridizes everything that I offer. Right? So I have courses, webinars, written drug information guides, you get the entire library of that through the member program.
Okay.
It also includes a drug information service. So people want to ask email-based Q&A, or I will respond via encrypted apps like Signal or WhatsApp. Sometimes I'll leave like an asynchronous kind of like voice message for the person.
Okay.
So that can be really helpful for, I would say, like facilitators, providers, organizations that maybe have intake forms with medications or illnesses they're not as familiar with or want a second set of eyes on. That can all be done through the member Q&A or the drug information service.
Okay.
Um, and then I also offer discounted rates on consulting. So, you know, like we said, okay, this antidepressant ayahuasca. All right, contraindicated. Wait 2 weeks. But who is this person? What are their illnesses? What are their goals for using it? You can
Right.
offer them a discounted consultation as a member. Um, so basically, if you're looking for consulting, I have a la carte consulting, and then I have
Okay.
the member program, which is a subscription, has all my
Okay.
resources, drug information service,
And that's
discounted
a
consults.
monthly membership?
Monthly or annual. Yeah, so it's a
Okay.
subscription-based program. If it's monthly, you're not locked in at all. You can join for as little as a single month if you want, binge all the
Okay.
resources, ask a bunch of questions or a few questions, and take care of it that way. Um,
Okay.
right. Or the annual one is you get a better rate paying annually, but you are kind of like locked in. Like I would not recommend signing up for an annual membership unless you're like sure that you want to work with me for a year, or at least like longitudinally like try the member program out.
Right.
um, but I also just offer, like, I would say, just other types of like education, right?
Yes.
All the way from, I have a monthly newsletter where I just do like a clinical roundup of scientific articles relating to psychedelics, and I send it out to my email list, right? So that's a free thing that many people really appreciate as far as getting like a nice kind of like clinical digest.
Yeah.
um, my blog page has lots of written stuff, vlogs, videos, things like that. Those are all free resources as well. I've got
Okay.
several free guides, one on psychedelic drug interaction and antidepressant tapering. I've got one on breakthrough psychedelics, so the pharmacology and interaction potential of MDMA, psilocybin, and ketamine. I've
And
got a
these are free to
5-MeO.
anybody.
Yeah, these are free, just downloads, right? Just freebies
Okay.
through the site. I've got like a 5-MeO DMT pharmacology and interaction guide. That one I made in collaboration with Five, which is like a 5-MeO education site.
Okay.
There's a couple of others too. I've got webinar workshops. So these are like recordings. They're fairly cheap. They're about $20 each. They're like 2.5 hours long. And then I
Okay.
have like my actual like courses, which are somewhere in the realm of, I don't know, depends if maybe you get a coupon or a sale, somewhere between like $50 and $300, and are more in the realm of 3 to 10 hour sort of like courses that really kind of go through things pretty systematically. So
Right.
I try and have something for everyone,
Okay.
from the sort of like downloadable guides, blog, newsletter. Those are all just like free resources, to the things that are more like workshop related. They're kind of, really good levels of information, that
Yeah.
are just kind of in the $20 range, all the way up to like the courses, which are way more systematic, or right, like a longitudinal consulting container for the member program. Yeah.
Right. And then, so if you can buy these things a la carte, or the free ones, or if you become a member, you have access to all of it.
Yes, exactly. So you can book a consult a la carte, no strings attached. It's a little bit
Okay.
more expensive. You can buy any of the courses or webinars a la carte. They're yours forever, as long as Spirit Pharmacist exists. You can join the member program, which is a subscription, and it's like renting my Netflix library of resources.
Mhm.
So all the courses, all the webinars, right? So if it's
Okay.
sort of like, I only want to know about serotonin toxicity and HPPD, that's my only interest in any of this. It's like, okay, just get the workshop about it then, right? But
Right.
if it's more like, man, I'm really interested in a lot of these courses, and I'm kind of tallying them all up, and it's pretty expensive to buy them all. Well, maybe you join
Become
the
a
member
member.
program for 2 or 3 months and binge it. You're
Yeah.
going to be able to do all the courses in a pretty short period of time that way, and you're going to save a lot of money versus buying them a la carte. But when the membership's over, you just rented them, right? It's sort of,
Right.
it's
And
like
what
buying the DVD versus getting it at Blockbuster, if that still
Yeah.
exists. Like,
I don't know if it does. I haven't seen one of those in a
I
long
don't think
time.
so. Yeah.
But what a great opportunity for facilitators as well, to especially to become members, because they have all of that access, and access to your second set of eyes on their clients. Correct, if need be.
Yeah. Yeah.
Hmm. Yeah.
So anyone could join the member program. Like, I have like a student
Yeah.
rate that's
Yeah.
just like resources, so it doesn't
Okay.
include the Q&A, and it doesn't include like the discounted consulting, right? But it's a cheaper rate if you like just want resources, and you're a student.
Okay.
Um, some people in the member program are just clients or patients. They're on their own journey.
Yeah.
They're tapering a couple of medications over 6 months. They're beginning to use psychedelics during that period of time. They want to ask me questions as they taper and things come up. They want to book some sort of shorter follow up kind of consults every other month as they go, right? So some people use the member program that way, just as individuals. But I'll say
Sure.
like the majority of people in the member program are clinicians, either therapists or physicians. They're alternative healers. They're retreat center organizations, right? So
Right.
they're persons that are involved in the practice of using psychedelics in one way, shape, or another, that want consulting around, um, particularly beforehand, but not always. Like
Yeah.
sometimes it really is like, what happened and why do you think that happened, and stuff like that.
Well, and do you get people sometimes who are afraid to go to their doctors and tell them that I'm thinking of doing this, and they don't want to let them know what they're doing, so they're trying to find a way to taper off, or find information about their medications?
Yeah, yeah. I mean, a lot of people don't feel that they can be honest with
Yeah.
their healthcare providers about their plans to use psychedelics. I usually do encourage them to try to be honest to the extent possible, right? Like, maybe you don't feel comfortable telling your doctor that you're tapering your sertraline because you would like to try MDMA assisted therapy, right? But I would still say that, well, I mean, you can go to your doctor and say, I've been taking sertraline for the last 6 years, and I'm not really sure how much it's helping my depression at this point, but boy, do I notice it in the bedroom. Like, it's much harder to achieve orgasm, and it's affecting
Right.
some of my like intimate life. And I would like to try a slow taper of this kind of could I have your support in that? Right? Like, I didn't say I was going to use MDMA at all, but I
Right.
basically outlined to my provider or prescriber that I'm not sure about the efficacy of this substance. I'm experiencing side effects of this substance. I would like to try to taper slowly, right?
Yep.
And I think if you do it this way, like explain it in terms of the efficacy seems limited, the side effects are noticeable or bothersome, I would like to slowly taper. Unless you really are one of those persons that has been unstable while tapering, maybe you taper the wrong way even, and it's not you, it's just like the approach was wrong the first time, right? But if it
Right.
really is that, wow, I have severe symptoms, I decompensate, I end up in the hospital, and your doctor says, I don't know, like, I think maybe you should stay on it, then try to understand the rationale, right? But if it's
Right.
just sort of, no, 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 you don't need to taper that. Why? Right?
Right.
Is it because my illness is so severe? Is it because I've failed tapering in the past? Is it because I've been suicidal? Because if it's like no, no, and no, and your doctor's still giving a lot of pushback, then
Yeah.
I think you can give a lot of pushback as well. Like, you can kind of be like, did you hear what I just said? I just
Right.
said that it's not working that well. I'm getting side effects. Does that sound like an optimal therapy for you? Right. But a lot of doctors are going to balk if you just come to them and you're kind of like, I don't really like this antidepressant anymore. I just need to get off. Like, I
Right.
think that, like, just need to
Yes.
get off, right? It shoots up the blood pressure because they, in their mind, they're thinking, wow, this person's just going to flush this antidepressant down the toilet next week, probably go into some sort of withdrawal syndrome or just kind of decompensate rather quickly from an abrupt withdrawal. It's going to be a big sort of problem, right?
Yeah.
And it's like, okay, fair enough. Um, so sometimes for good reasons, a doctor may put up some resistance against tapering, but I think most of the time it's not very good reasons. And if they really listen to the person and the person themselves had good reasons, like it's not working that great, and there's some kind of like side effects, and will you help me with a slow taper? I mean,
Yeah.
it just seems unreasonable to say no to me, right? Like, it just
It does. It's an important conversation, and people need to be honest with their healthcare providers. They need to be honest with their facilitators or wherever they're going to have ceremony. You just have to be honest. You just have to be
yeah.
honest with all of this.
And surprisingly, a lot of people, they're not necessarily working with me because they can't talk to their doctor. A lot
Hmm.
of the time, they're working with me because they did talk to their doctor. Like, they
Hmm.
talked to their doctor and said, I want to taper off, and I'm really curious about MDMA or psilocybin. And their doctor says something like, I'm really curious about those too. I've heard a lot about them. It seems like really promising.
Yeah.
I haven't gotten any training about that. That's not something that I know very much about. And I'm feeling uncomfortable just being like, yeah, go ahead and do that. But, you
Right.
know, I would like to talk with this psychopharmacology consultant on the internet. The doctor looks at the website. The doctor's kind of like, I think that would be a good idea. Why don't you book a time with him, and then we'll come back and we'll chat about what they talked about, and we can go from there. Like, that's a lot of the time how it's working,
Yeah.
more than I just can't talk with my doctor because they're going to judge me, and I'm coming to you because you're the only. Sometimes it's like a PCP is managing the psychiatric medications, where it's just kind of like, okay, they inherited me from a psychiatrist. They keep writing the prescriptions because they know that if they don't, then I'm just going to fall off my psychiatric meds. But it's not
Right.
like they started those or feel like they're in charge of them even, right? Or know
Right.
what to do about them. Or some people just have a psychiatrist or doctor that retires, they move state, right? They're just sort of in between providers for whatever reason. And I'll say, like,
Yeah.
those situations are actually probably more common than I cannot tell my doctor about any of this because I'm going to get labeled as a drug seeker and this and
Yeah.
that.
Yeah.
Yeah. I
Yeah.
mean,
Yeah.
that's definitely possible with some doctors, but yeah.
Well, Ben, this has been an incredibly informative conversation. I could go on and on with you about this. I'm going to have to
Yeah.
sign up for your webinars for sure. You've got a great one coming up. I saw an email this morning about microdosing and macrodosing, um, and all the information to know about that. So we appreciate you coming on and talking with us. We can continue this conversation maybe someday in the future. You can
Yeah.
find Ben and the Spirit Pharmacist on any information on the plant medicine path, as well as his website, which we put up here. We appreciate you so much. Thank you.
Yeah, it's been an absolute pleasure being here, and maybe you can tell that I can go on forever too.
It's so I love it. I love it, and it's just such an important conversation. And Mark and I started the plant medicine path because we wanted people to really have a place to come for ethical information, education, and you know it's just so important to have that information out there. It isn't just about going in and taking a psychedelic. There's a lot more to it than just that. There's a lot to it. So having your education and resources is absolutely incredible. I know you're a valued member of the plant medicine community and the psychedelic community. So we appreciate you. We're going to have you back.
Thank you. Yeah, I'd love to come back sometime.
Okay, sweet. Thanks so much. Have a great day, guys.